Good day, everyone, and welcome. I'm Jack Van Horn from the University of Virginia, and I'm very proud to welcome you to this edition of our 2022-2023 Foundations of Biomedical Data Science seminar series. This lecture series is supported by UVA's Integrated Translational Health Institute of Virginia, the UVA Brain Institute, the College of Arts and Sciences, the School of Data Sciences, and through a grant from the National Institutes of General Medical Sciences. Since 2016, the Foundations of Biomedical Data Science seminar series has focused on the use of data science methodologies, artificial intelligence, deep learning, and statistical modeling as they pertain to different themes in the biomedical and health sciences. The chosen theme for this year is data science and the public health consequences of the COVID-19 pandemic, where we will enjoy presentations on Fridays at noon from leading thinkers about the issues, promise, opportunities, and hurdles associated with understanding the secondary health effects of the COVID-19 pandemic. These include, but are not limited to, delayed health checkups and treatments, mental health, drug abuse, increased obesity, and the long lingering health effects associated with the SARS-CoV-19 virus. We are in the process of receiving applications for our 2022-2023 application cycle, and we encourage junior faculty members working in areas such as infectious disease, epidemiology, public health, clinical medicine, population studies, as well as data science, machine learning, AI, statistics, and other relevant domains to consider applying. We believe that this will be an exciting and engaging program where characterizing the secondary health effects of COVID necessitates unique quantitative approaches, but also new multidisciplinary collaborations. Participants selected for our Biomedical Data Science Innovation Lab program will leverage the presentations, like the one you're about to hear, as vital material for our culminating in-person grant project development workshop to be held at the Lodge at St. Edward's Park in Seattle, Washington in June of 2023. Today, I am delighted to welcome our speaker, Dr. Melody Greer from the University of Arkansas for Medical Sciences. She has a Doctor of Philosophy in Computer and Information Sciences from the University of Arkansas at Little Rock. She has a master's degree in information quality and graduate certificates in health science innovation and entrepreneurship and in applied statistics. She has a number of activities that she's involved with, namely participation in activities of the American Statistical Association and the International Association for Information and Data Quality. Dr. Greer's research interests involve data quality and integration following years of work in government and business, both independently and directing teams in the collection, maintenance, and integration of data. Melody decided to pursue her Ph.D. and develop a deeper appreciation of the underlying processes at work, which culminate in well-integrated and high-quality data. Today, she leads a team working to do research on data enhancement, quality, and interoperability in the healthcare field. In continuing with our 2022-2023 Biomedical Data Science Seminar Series theme, Melody's lecture today is entitled Data Enhancement and Portability for Healthcare. Melody will be discussing the paradox that while socioeconomic and behavioral aspects of our lives significantly impact our health, there's actually minimal social determinants of health data that gets collected as part of the healthcare system. Information of this type is needed for quality healthcare research, for patient care, in particular because it is associated with the full spectrum of health outcomes from acute to chronic disorders. And in spite of the growing interest in including social determinants of health data in healthcare process, there is a significant challenge associated with its collection, management, quality, and portability. And Melody and her team work very carefully in this area to provide answers for addressing some of the challenges which exist. As always, we are streaming this lecture live and for recording via YouTube. And if you are watching on YouTube, thank you so much for joining us. Also, our specially selected 2022-2023 Biomedical Data Science Innovation Lab participants and alumni are encouraged to submit any questions they have for Melody via their Zoom sessions. I will personally synthesize these questions and ask them on your behalf in the last 10 minutes or so of the lecture. And with all that said, welcome, Melody. We are super excited to hear from you and hear what you have to tell us.
Hello, everyone. My name is Melody Greer, and I'm here to talk to you today about data enhancement and portability in healthcare. This work has been the result of a collaboration with Dr. Sudeepa Bhattacharya from the Arkansas State University, and we are working currently on understanding the relationship between colorectal cancer and the social determinants of health with this awesome team you see here. I want to shout out a thank you for the NSF funding that supports our work, and the DART project in Arkansas that is the recipient of the NSF that has that supports what we are doing currently. So today I'm going to talk to you about two main ideas. The first one is that social and behavioral data are important parts of healthcare. And then the second one is we can get this social and behavioral data without making people answer survey questions. No one likes to answer survey questions. So first, let's talk about the types of data that we have available to us at my university, and I'm sure at many others, but we have some unique features at our university. First, we have molecular and cellular data at the ArcGIM project. We also have imaging data from the Cancer Imaging Archive. We, of course, have clinical data from our EHR that runs in the hospital. And we are the home of the Data Coordinating and Operations Center for the ECHO Child Pediatric Clinical Trial Network. And there we collect data for each unique study that is run through these multiple centers. So we are focused on clinical and research data right now. We have hopes to add in imaging and molecular data as we move forward, but as a first step, we're working with clinical and research data. So by clinical, I mean electronic health records, and these are gathered manually as doctors visit with patients or in an automated fashion for patients who are perhaps in the hospital for an extended period of time, and they're being monitored for vital signs or blood oxygen. We're also interested in the electronic data capture systems that are used for clinical trials. These are flexible and customizable software systems that are built for each individual clinical trial, and they have to be tailored to the trial itself. And we're interested in developing social determinants of health to be integrated into both of these types of systems. So social determinants of health. Probably a lot of you know what those are, but just so we cover anybody that has not been listening lately, the social determinants of health, according to the CDC, are the conditions and the places where people live, they learn, they work, they play, and all of these things affect the quality of your health and your life overall. What's surprising is what a large impact the social determinants of health have. They drive 80% of your health. What that means is only 20% of your health is actually related to seeing a physician. The rest of it is all about the rest of everything else that happens to you. And what's stunning and concerning is that 40% of premature deaths result from things that are lifestyle choices. We're hoping with our work that we can help to address that particular issue. This kind of data is clearly important for physicians to have. It helps them with risk prediction, and it also helps them with clinical decision making. Social determinants of health are associated with a wide range of disease. I've listed some of them here. There are many more. With this information, clinicians can connect patients with services that are available to help them with whatever social determinants they might need. And I'll take a second to explain social determinants of health can be both positive and negative. Things like exercise are positive, and things like maybe a stressful neighborhood or bad food choices would be negative. And so if there are negative determinants of health that a physician is aware of, these people could be connected with things that might help them recover or improve from that particular social determinant of health. This is the kind of data that they don't have. And the reason is because it's very difficult to collect. There's minimal social determinants of health data collected right now. And what is collected is non-standard and it's incomplete. Efforts are underway to try and improve this situation. Typically, a clinician will talk with the patient and maybe put some of this information into the notes. Community level data has also been one of the ways that people have suggested to backfill these particular data elements, but surveys are the primary solution right now. The problem with that is that providers are already overloaded, and this is another type of data entry basically for them. And so the data is often non-standard and incomplete for those reasons. And then when it comes to analysis, the data that we're provided is fragmented. It comes from all sorts of different sources. So it's very difficult to analyze. And the patients are not excited about it either, because they have to fill out multiple surveys and they have to fill them out repeatedly. So we're developing an automated process to provide individual level healthcare data that has a social context included. And I highlighted individual level here for a reason. I talked about community level data on the previous slide. And what that means is data that is at the zip code or the census tract level. Community level data that is used for social determinants of health for data elements is maybe less accurate. Well, it's definitely less accurate. Let's give you an example. So if you think about an urban area, maybe a particular zip code, there are people that live in that zip code who might make a large income, and there are also people in that same area who make a very little income. If you take the average of those two groups and you use that as your data point to think about the income of the people that are being treated, what you'll have is a number that doesn't refer to anyone in your sample at all. And so for that reason, it's not only about income, it's about all of the different variables. If you take these types of ideas and you take an average of them, you're going to miss people no matter what area they live in and no matter what type of methodology you use. And so we are focused on providing individual level data points as social determinants of health. And we want to deliver them in a standard way that is complete, it is current, and also this data must be portable in a way that it can be integrated into any health system. So we've done some preliminary research on this, and we have a couple of papers out and a couple in progress still on COVID-19 and social determinants of health. And what we did was we gathered everyone in our EHR that had risk features that would put them at high risk for COVID-19. And we evaluated the ones that were positive and those that were negative against geographical considerations like urban or not, and also health literacy, which we used a combination of health interest and technology interest, and also the area deprivation index, which is a community level variable. So we took all of these different combination of variables and we looked at patients who were located in less urban areas, and we found that patients were more likely to be COVID positive if they had a lower health interest and technology interest. But that's not true, wasn't true for our urban patients. what was most interesting about that study and gives me a lot of hope is the fact that this was not related to their socioeconomic status. We were able to actually separate out these two individual social determinants of health, which is a big problem with social determinants of health in general. They tend to be intertwined. And so untangling that is a challenge. And we were able to make a start at untangling some of that data. Also, as we did this work, we also discovered that COVID positivity was associated with many of the things that we expect, like population density, age, race, household size, but it wasn't related to the area deprivation index. So this is a diagram of our process that we are building. It's a high level diagram. We start off with consumer level data, and we end with enhanced, portable, clinical data that also has social context. And I will explain each of these individual pieces as we go through the next few slides. So we'll start out with commercial consumer data. Commercial data is built by compilers that this is their business. They gather data from transactions that everyone makes, and they aggregate it together, and then they resell it to marketers in order for the marketers to identify people that might be interested in particular types of products. This is primarily built from financial transactions. It is like discount cards, also credit cards. Anytime you make a credit card charge, discount cards like you would use at the grocery store, phone apps when you download anything on your phone. All of these things are transactions that get gathered up by commercial data compilers. The only people that really escape the net of the commercial data compiler is someone that is on a cash basis only. If you're only making cash transactions or barter, I suppose, then those things will not show up. Other than that, and that's very few people now. You would also have to not have a phone. Those would fly under our radar. So these commercial elements are mapped over to social determinants of health using an ontology. Now, I'll also say that there has been, I have heard some people concerned about data privacy for individuals. This data has been given over by the people themselves in exchange for an app or a discount. And the data exists out there and is being used to market, to get people to buy things. It is our hope that we can use this data to actually help people, to bring it back to the people that gave it up in the first place, to whoever it was, to, like I said, to get a discount or to get an app on their phone, and to provide that a service back to them. So I have a poll, and I hope that everyone will have a look at this and answer these questions. I would like to know if I have convinced anyone that social determinants of health it's okay for your clinician to have that information. And I'll leave up this QR code for just a minute. And give everyone a chance to respond. You know, whether we agree with that or not, I would love to have feedback from anybody about the reasons why they would or would not be comfortable with that, and what might help to make them more comfortable. These data points are being collected and used in any case. Whether we take them and use them to help people with healthcare or not, they're still being collected. So I'll take a peek and see. Well, we have one answer. So maybe I'll give everyone just another minute or two. I'll put the QR code back up. Oh, good. Okay. The survey will stay open for a minute as we move through the next few slides. So the next component of our process is the clinical data. And this is what I was talking about before in previous slides, the electronic healthcare data or the electronic data capture system data that comes in from randomly controlled trials. These two sources are linked using entity resolution, and that works by using non-unique identifiers in a group to join two or more data sets. And this makes our complete data set. We'll then have the clinical data plus the commercial data that is mapped over to the social determinants of health. But this data is also refreshed, all of it. The clinical and the commercial data must be refreshed on a scheduled basis because, as we all know, things change. I decide to go on a healthy diet or start a new exercise program or quit smoking or start drinking, whatever the options might be. Your life changes as you move through time. And so we have to make sure we capture that or the data is inaccurate. The next step is a data quality assessment. The data quality assessment includes completeness, which is making sure that there's no missing elements. And in our case, we have a novel imputation method that Dr. Bhattacharya is building out that we're very excited about. We're also going to measure accuracy, which this is like a surrogate for accuracy. There's many definitions, but what we want to make sure is that this data is mostly within our bounds of expectation. We'll make sure that it's timely, that it's fresh and current. And so we'll measure all of our refresh dates for the different elements to see that everyone, all of the patients that are listed, as well as each of the features, are refreshed on a regular basis. We'll measure coverage, and coverage is a commercial, coverage is a different type of measurement that is only used by social determinants, by commercial data providers. This is an idea of if all of the patients are listed, then not in a clinical set, not every one of them will be found in the commercial set. That is, some of the people, whoever is living on a primarily cash basis, may not show up in the commercial set. And so this is the idea of coverage. We'll also measure relevance, which is the perceived value of the data by people asking to use it. So we want to build a data set that is, of course, useful. We also want to measure decay. That is the rate of change of data. How quickly does it fall off and switch to something else? And at the end, we are left with enhanced clinical data. That is the data that the clinical data plus the commercial data mapped over to the social determinants of health. And importantly, it's in a portable format. And we have tested out this process in a study recently where we built out the enrichment process and integrated all of this dynamic social determinants of health and did it on a repeatable basis to see that we could move through all of that process. We did the mapping. We haven't completed the ontology work, but we did mapping to the Healthy People 2030 elements. And we demonstrated that this is a viable source of social determinants of health at the, again, individual level. So I have another poll. The poll that we just did asked if you were comfortable with having social determinants of health used by your physician. This one is asking you, in what way, if these elements, your social determinants of health, were gathered up and it was determined that you were at risk, I'm guessing that you'd want to know, how would you like to find out? I'll put the QR code back up. The survey would still be live if you were doing it through your phone, though, and it should switch over to this one. Rank how you would like to be informed of this particular problem that could affect your well-being and your health outcomes. I'll put that back. If you just refresh your phone browser, it will show up, and then you pick whichever one you think is interesting, and you can move it with the arrows beside. And then you hit submit. Yeah, and this is not a surprise. Many people would like to hear this from their doctor. And so when we provide this information through the EHR, doctors will have it. But it's also going to be available to researchers. And we're hoping that there's also other mechanisms where people can be informed, warned that they're at risk, and here's why. Okay, now we're down to portability. And interoperability has been a big problem in healthcare. The definition of interoperability is health data that flows between different providers without any difficulties. When this works well, it prevents inconsistent information on patient health records. It minimizes unnecessary medical procedures. You've heard of people getting the same procedure more than once because the health records are not shared. It helps clinicians to collaborate and build integrated treatment plans for their patients because they don't always have time to, or even know that they need to, connect with other providers that these patients are seeing. And so this is a way of keeping the clinicians involved in the patient's care process. And so how are we going to do that? We're going to use FHIR. Fast Healthcare Interoperability Resources is a data standard. It defines how healthcare information can be exchanged with different healthcare systems as defined by healthit.gov. It has wide acceptance in industry with most of the EHR vendors, Epic and Cerner and others. It also has buy-in from our big software companies, Apple and Microsoft and Google. It's based in already existing web standards, which makes it easier for us to move forward in that direction because there's already people with these skill sets, things like XML and JSON, et cetera. And it's also human readable. But that's not all. It also has a social determinants of health component. And this evolved fairly recently, but it started out because in 2009, the HITECH Act required that patient data be in a standardized format so to support interoperability. Initiatives then started to collect social determinants of health. In 2017, for example, the Centers for Medicaid and Medicare started to require providers assess the patient's social risks. And so in 2018, the Gravity Project was started, and it is built from a group of stakeholders that want to build out a set of social determinants of health data elements that can be used for interoperability between all providers. And this is just to make sure, this is the portable format that our data will finally end up in. Currently, in our NSF work, we are working with about 200,000 rows of patient data. We are in the process of working on the ontology and the fire conversion section of this, since we have already tested out all of the rest of it. And in parallel, we're working to apply our methodology to a colorectal cancer screening and rate study that was with the team that I showed at the very beginning. The outcome of all of this work is going to be an expectation of patient social context being included with healthcare data. This is going to support clinical care, as we discussed, at risk estimation and helping clinicians to connect patients with services. It's going to support research into social determinants of health to help to untangle some of these issues that we know are there, and we don't know which is the primary problem. If we can become aware of the various aspects of social determinants of health, then we stand a chance to actually pinpoint the problem areas and make improvements or make corrections. This is also helpful for operational reasons. It helps to reduce procedures, which of course saves expenditures and reduces costs. And finally, from the public health perspective, it supports prevention and control of chronic disease. So this is my presentation. I've got my email here on the bottom. I would love to hear from anyone who has thoughts on this, and I'm hoping that we have lots of questions and discussion. I'm going to put up a feedback survey. I hope that you guys would be willing to provide me some feedback so we can make everybody interested in and get lots of feedback to improve our work.
Melody, thank you so much. That sounds like a fascinating project, and I can see multiple points of intersection where people interested in data science might be able to plug in. From your perspective, what do you think some of the what some of those places might be?
Well, so we have, of course, the fire and ontology are the very technical aspects. We have clinicians interested in our work from the perspective of their particular area of focus. We also have people that are interested in data quality from the perspective of how can we do the data quality assessment. This is going to be, I mean, as we move forward, right now it's only 200,000 rows, but that's just the beginning. I can foresee this at a point where we have many more rows of data, as much as the commercial data compilers can provide. So I think that no matter what, even honestly, even operational folks will have an interest, because this work pretty much runs the gambit. And because the government has an interest in rewarding the collection and use of social determinants of health, I think that honestly, I can't think of anybody that couldn't find a way to plug into this type of project.
I'm curious about some of the how one defines some of the social determinants of health, just from the perspective of, you mentioned several standards organizations, or rather just standards that are being brought to bear here, like the fire standard. I believe there was one or two others. And I'm just curious, like, who participates in those committees to help determine what social determinants of health one should be looking at. Does
You
that make
know,
sense?
yeah, it does. And, and that's actually another really good way that people can participate, not specifically with our work, but with the Gravity Project. And there is, if you search online, the Gravity Project is available for anyone to participate in, which is really, really nice. I am a member, but I think that there are different levels of participation, I'm sure, depending on your time and interest. So yes, you and me and anyone else that is in academics or business or governmental functions can all have a say in this and in the way these elements are developed and put out for everyone to use.
Can you tell us a little bit more about the Gravity Project? I mean, you mentioned it in your slide, but how long has it been going on, and how big is it, or who are the prime movers of the Gravity Project? That kind of level of detail.
I am not that knowledgeble about the Gravity Project as far as who the prime movers are. Now, I do know that it was started in 2018. It's funded by the Robert Wood Johnson Foundation, I believe. Mm-hmm. But they have very nice websites where you are able to go in and look at the elements that are in development and participate at that level. Unfortunately, I don't have more information than that.
Okay, that's fine. you don't need to speak for them, but I was just kind of curious if there are opportunities for people who are thinking deeply about ontologies and then what one can do with them, and especially thinking about people who are from communities where social determinants of health might be, they may be the most, what's the word I'm looking for? They're the ones who's the measurement of social determinants of health are designed to address.
Yes.
And that they would like to have a voice in the description of what those social determinants are, how are they measured, how are they codified, and then what one can do with them or not do with them.
And that is such a good point. And that is actually part of the community outreach that needs to happen, because honestly, I wouldn't be surprised if a lot of our audience here was aware of FIRE or social determinants of health or even the Gravity Project. But honestly, it's not something that a lot of people, especially just regular people, are aware of. And I think that is actually a good case for our work, because we would like to have some community outreach to individuals so that they know that they even could contribute, right? I feel like there's not a lot of awareness out there.
I think you made a very important observation and comment earlier on in your presentation about people from kind of more rural environments who may or may not have been, there was a differential between the people in a rural environment versus an urban environment, and their it was like their technological I can't remember how you said it. Yes. Like whether or not they're technologically savvy. And one of the things that occurred to me was that, they're probably very smart people. They just may not have access to the internet that you might have if you're in, New York City versus, a rural portion of, southwestern Arkansas, for example,
Or
and I'm just kind of thinking, is it an availability thing? There's just not the service providers who are, basically dragging cables or fiber optic lines to those communities so they have ready access.
And I've heard a lot about this. There was a study, and I wish I could remember the name of it, but there was a study that said that everyone, even in the most impoverished parts of the world, everybody has a phone now. And I don't remember the study, so I can't really support that. But what I have personally seen is that is quite true for even our most non-urban communities in Arkansas, which is the better part of Arkansas. You are correct. They don't have the kind of access that we do in a city. They're internet providers are not, it's just not as good what is there, and it's definitely limited, but they do, almost all of them have cell phones. And so I think that is really the path to reach people most completely. And the fact that the compilers found these people had an interest in technology and an interest in health means that they were finding a mechanism to look this information up, or they wouldn't have come up on the radar like that.
Another thing that you had mentioned is basically one of the drivers of your study, and you talked about it early on, was using commercially collected consumer data. And I have long thought, like, why are we not doing a better job of, as health people interested in healthcare, of tapping into that trove of information that would help us to determine, like, basically what kind of foods people are buying, so that when we see that they've got health concerns, we're like then having to go and ask them, as you point out, asking them to fill out some raft of forms about stuff. We would know, or rather we would at least know about communities if we have to anonymize the data. And I really like that concept, and I'm kind of curious if you could tell us a little bit more about how you get access to that data. Are there any restrictions on it? I presume there's some proprietariness to it through the providers. I don't know. Can you tell us a little bit more about your experiences with it?
Absolutely. And this is a subject that is near and dear to my heart. A lot of people feel like that this is evil. They they have all this data, but I think you're absolutely right. It's not inherently bad or good. It's something that we can take and we can use to provide people what they need, actually. And so commercial data is like you said, is collected by these big data vendors, and it is they run the gambit from very, very large data vendors to small companies that collect smaller amounts of data and even aggregate community level information and resell it. So to get this information, if you want the community level information, you can go get it yourself for free. If you want the community level data aggregated into groups where you don't have to go to the trouble to hook all those data sets together yourself, you can buy that for fairly cheap. If you want data about individual people from a commercial data compiler, you have to pay for it. And it is, I liken it to buying a car. You can go and buy a car that's a stripped down model where you can just get the standard car with the standard features, or you can start adding bells and whistles. I want nice rims and a moonroof and some sort of sound system or whatever. Each of these features that you add increases your cost. And so your cost is calculated based on the variables that you choose, how many rows that you're looking to have appended, and what sorts of variables. There are, of course, premium variables and then cheaper variables. And the commercial data comes in kind of two formats. There's the raw data that we are interested in, that is just the information brought directly that we purchase directly. And then there's also proprietary variables that are specific to the vendors. And a lot of times these are really interesting and good variables. They're modeled. We don't use them because they're a black box. I don't know how that model was built, so I can't really speak to it. That's not to say it's not valuable and somebody couldn't find a way to use it. I think you probably could, but we, to this point, have shied away from those and stayed with the specific raw variables that the vendors can provide. But they're also very happy to talk about and to sell you the proprietary variables that they have modeled themselves.
Now, does that data come to you sort of pre-ontological ontologified, if you will, basically in a format that's already in an ontological framework, or do you then take that and kind of re-ingest it and remap it into an ontology that you're using?
We have to map it onto the ontology. They make data for marketing, and that's what they sell. So when you get it, it looks like, do you have a puppy? Do you own a car? Do you want to buy a boat? Do you subscribe to magazines about motorcycles, or all of I've just popped off a few elements that would be on that list, but it's an incredibly wide data set that they can provide. And I'm talking in the thousands of data elements that are available.
So thousands of data elements per for every one of the 200,000 and growing list of people that you're working with now. So that's quite a sizable data set. Have you seen or discovered any unusual relationships that seem to pop out that perhaps you didn't expect, or that were surprising to you?
I was stunned, honestly, when we did our first stab at this and discovered that socioeconomic status could be teased away from the idea of health interest and technology interest. A lot of times we think about people and we think, socioeconomic status is very much tied to your interest in technology, the things you like to read, the things that you care about, your educational level. We expect all of these things to be tied together. And that little part of that study was so exciting to me because, first of all, it said, no, that's not true, period. It doesn't matter. Or at least in this case, I won't try to generalize too much, but I definitely now want to pursue that into a broader area. But that's part of the core problem of the social determinants of health that we have right now today. The fact that we know there are positive and negative aspects, but we don't know, it's a chicken and an egg problem, right? We don't know which of these things is primary. And so we don't know how to fix it. And it's encouraging to know that you can take socioeconomic status out of that equation, and then you can just go and help somebody become technologically literate, become health literate, and you've helped them to do that without having to meddle in every other social determinant of health, because that makes it feel like too big of a problem, right? When you can take these small bites, that's how you eat an elephant, right? Little bites, one bite at a time. And so if you can break this down into these different components, then you have a much better chance of actually helping people.
Do you see opportunities for people who are doing like machine learning methodologies, text mining, natural language processing, and like electronic medical health records, people who are working in those kind of areas? Could they dive into data like this and just go crazy for years?
Oh my gosh, yes, that is something that, and we have students that are so very interested, because we are going to have such a rich data set and such a unique data set. This really lends itself to, especially as we're talking about such wide, numbers of elements, that you actually need to think about this from an AI perspective. And that's actually, I can't talk to you a lot about our novel imputation method, but that is part of the work that we're doing just to build the data set in the first place for the people that maybe for whatever reason didn't get into the coverage. We'd like to see if we can expand our understanding of everyone, and thereby use this information to talk about even people who, at the best case scenario, would be even to be able to look at people that were temporarily homeless and such. But yes, this type of data will lend itself extremely well to what you're talking about, machine learning, natural language processing. Not currently. That may depend upon the data that we are able to integrate with. And like I said at the beginning, we have an interest in integrating with not just the data that is what I would call well-formed and easy to work with right now, the research data and the EHR data, but we want to integrate with image data and molecular data, which not that they are harder for us to be able to integrate into our work, but these also provide rich areas for study and grow this data set even more.
I think it would be just fascinating to have, some a group of data scientists. I mean, it sounds like you already have a group already who are working on this. So I'm hoping that I'm in the right spirit here, that have data scientists go in there, basically mine this resource that you are constructing here, because you'd be able to identify communities where, like, that data technology literacy is, it could really be impactful. You could also find places where, it wouldn't be necessary. And so, you can direct resources accordingly. And I can imagine it, bubbling up to being, policy, people in the policy space really finding that helpful. Lawmakers and, civic leaders would be able to utilize this kind of information in some of their programs.
That is absolutely our hope. And actually that's part of the reason we have the metrics designed the way we do. We have people, and much like you're saying, the data scientists that are interested in doing the work on the back end to build out data and to do data curation. And then you have this next level of people like clinicians and researchers who want to take and use this data to find out what the problems are and where they are and how they can help. That is part of our colorectal cancer screening study. We have students that are doing geospatial work. We have students that are doing work to find out cancer staging. So yes, this is absolutely true. And I'm excited about the opportunity to expand this all the way up to policy. We have our Arkansas Department of Health. We have a representative from there that is an epidemiologist as well on our team.
Yeah, I think that things like resources like this become so important for things like that. One question I do have, though, is how does your ontology, how do you decide to grow it? Like, if you mentioned having, say, 1,000 different metrics that you're tracking, well, what happens if you discover 10 more and you decide, oh, we want to update the ontology? My experience has been when you try to change an ontology is after a while, it becomes like concrete and you just can't chisel into it. And they're very hard to expand once you get them started. Is there a process that you guys look to kind of evaluate and vet possible changes to your ontology so that you're not trying to chisel through concrete more times than you need to? Does that make sense?
It absolutely makes sense. And you have me at a disadvantage. Ontology is not my area of expertise at all. We have an ontologist on our staff, on our faculty, Matthias Verhausen, and his student is working with us on our ontology development. Mm-hmm. And so this is part of their work. They will be participating in our project in that way. And I certainly don't have the level of expertise. I am actually excited to see how they will proceed with creating the ontology. We started off originally mapping these concepts across in a very primitive fashion, just as a proof of concept, and immediately knew that we would need to do this in a more scientific way. And so I am very excited that they're interested and cannot wait to see how that turns out.
Is there going back to data scientists, is there a role for data scientists to help determine what the best dimensions are to grow in that ontology? So in contrast to, say, getting a bunch of super smart people to sit in a conference room and debate about what ones, what elements to add, could the data itself suggest areas where you could add the ontology and grow it?
Oh, so you're suggesting that maybe some sort of machine learning technique? That's an interesting idea. I think that there's potential for that. I think that the social determinants of health that that will end up finally being part of our portable data set will be in a large part dictated by both the governmental mandates, the Healthy People, and also by the selection set that the Gravity Project sets out. However, I will say that the Gravity Project is open to taking on variables and building them out based on community input. So I think that these variables will be selected by multiple means. I think there'll be multiple inputs is probably the best way to say that. And I absolutely think there would be a role for data science in that.
Yeah, I would think that you'd want to have, kind of multiple ends of the spectrum, being one end of the spectrum being, say, community advocates, right? Who are suggesting you really need to be measuring, factor X about this community because it's really important, to having machine learning methodologies crawling through the data, identifying relationships, and perhaps identifying gaps where you could go in and collect a variable that is going to help fill that gap and help, make a bridge that perhaps needs to be included. And so there could be enormous feedback loops between those ends of that spectrum as well. So there's lots of interesting things that could be done, I'm sure.
Yeah, that's why we're so excited. I feel like there's going to be just opportunities galore for many different aspects of this work, and that is useful for people of different skill sets. And I think you're absolutely right. I would be excited to see how that will turn out as well.
Melody, one finally a question here. What sort of things has this resource really helped to tell us about? It's the secondary health effects of COVID-19, whether it's national or whether it's regionally specific, within Arkansas or Arkansas as a state, or just a county within Arkansas. Have you gotten any insights into what some of those secondary health effects, how they might be modulated by some of the social determinants of health?
We have specifically focused on COVID-19 because that was what our pilot study data was around. And so, yes, we did find out that the area deprivation index was not very helpful for that. That household measures were helpful as well as individual level measures. We are hoping that as we apply this to colorectal cancer in a more targeted way, that we're going to be able to understand why some people get screening and why they don't, depending on where they are and who they are, what makes you interested to get your screening as recommended. We're hoping to understand incidence and prevalence as well across our state. Our work has been focused on Arkansans to this point because that's the data that we have access to. But as we grow this work, we absolutely intend to go more broadly about it. And we're hoping to partner with institutions across the United States in order to get a more general idea and generalizable data. Since, like I said, we're right now focused on our specific institution.
Yeah, I was just, kind of curious whether or not you might be able to detect a dip in colorectal cancer screenings during the pandemic, right? Obviously, people were locked down; they weren't leaving their house because of the obvious reasons, and as a consequence, the colorectal screenings went down. And now we're seeing, now that we're sort of emerging from that time where we were locked down, now you're seeing a greater incidence. There's this now a spike in colorectal cancer diagnoses because now people were not getting the screenings that they needed to get.
Yes. I think I think there's opportunity for that. I think there's a lot of opportunity around cancer in general and specifically colorectal cancer once we understand better the social determinants of health of our particular populations and start to try to tease that apart.
Well, Melody, thank you so very much for sharing your work with us and having a wonderful discussion about the social determinants of health and how your project is seeking to kind of capture those and then to relate them to things like colorectal cancer and COVID-19 and hopefully other things as well. What a fantastic resource. Thank you for sharing it with us. And thank you everybody for joining us. We will look forward to seeing you next week.
Thank you so much.
Thank you.
Bye-bye.
Have a good